So hello, everybody. I'm R.J. Tesi. I'm the CEO and Acting Chief Medical Officer of Immune Bio. And today I'll be hosting this Bench to Bedside pre-CTAD webinar highlighting alternative approaches to treatment of Alzheimer's disease. And hopefully you've been able to log on. There will be a time for Q&A at the end of this where you'll be able to ask our experts questions, and the presentation will be cached with a link on the website probably within 24 hours. So today you should see the second slide, which has the pictures of the participants. Malu Tansey is one of the really shining lights in the world of neuroinflammation as it relates to neurodegenerative diseases. Dr. Sharon Cohen runs the largest memory clinic in Toronto, and Dr. Larry Friedhoff is really one of the deans of the drug development fraternity in Alzheimer's disease. And they will each give us a short presentation, and this will be followed by a really a panel discussion peppered with questions that hopefully you will deliver. So having said that, we'll move to Dr. Tansey's presentation on the role of neuroinflammation in Alzheimer's disease. And Malu Tansey is the Norman Fixell Professor of Neurology and Neurosciences and the Director of the Center for Translational Research in Neurodegenerative Diseases at the University of Florida College of Medicine. So with that, Malu, I'll turn it over to you.
Thank you, RJ. Just a few disclosures about some industry affiliations, grant review panels, editorial boards, and some funding. I'd like to start out with the first schematic, which tells us what the current view of the amyloid hypothesis is and what the current view of inflammation in Alzheimer's is. And the point here is that you view the disease, your view of the disease really determines how we approach the treatments. And the current view is that amyloid is the linchpin, which is why there are so many amyloid therapies being developed, that amyloid is the linchpin behind Alzheimer's disease, that you have neuronal overproduction of amyloid beta and tau, and that this initially triggers an adaptive microglial response that's protective, but then eventually they can't keep up and they become overactivated, dysfunctional, and they perpetuate the chronic inflammation and they contribute to neuronal death. However, it's important to recognize, as shown in this next slide, that the genome-wide association studies, or the genetics, actually tell us that it is very likely that there are immunologic deficiencies in genes that are only expressed in immune cells. And so this quote from Julie Williams is, if you just look at the genetic risk factors that are emerging for Alzheimer's, you would think it was an autoinflammatory disease. And in fact, over 60% of the genome-wide association hits are for genes that are only expressed in glial or immune cells. And so this should point in a direction of not just neuronal mechanisms, but mechanisms that involve non-neuronal cell types as potential contributors to the disease. And in the next slide, we can see that it is not just about amyloid phagocytosis or amyloid removal. The genetics actually indicates that there are several different components of the innate immune system that involve cell surface receptors, cytokine production, production of trophic factors, migration of cells, and in fact, many of these could synergize to give immune dysfunction. And so we feel that the most appropriate and successful treatments in these chronic neuroinflammatory age-related diseases like Alzheimer's will be those that normalize immune dysfunction. And in this next slide, let's look at how early inflammation starts. So this should be a little bit surprising, but perhaps not to everybody. The genetic data suggests that immune dysfunction is happening, but the fluids and the epidemiology tells us that it starts in the third or fourth decade. So if you have inflammation, some of the best predictors of cognitive decline are cytokines like tumor necrosis factor and tumor necrosis factor receptors, which are also shed into the bloodstream to try to sop up that soluble TNF that is circulating in the bloodstream and trying to keep it away from tissues where it can do some damage. And then animal studies have also shown that soluble TNF as well as IL-6, which is produced in response to TNF, have also been linked mechanistically to amyloid-related and tau-related pathology in animal models. So if inflammation starts early and we are not thinking about treating these diseases until 2 decades later, we're going to be, behind the 8 ball. And in this next slide, what we want to convey is a new view of how neurodegeneration occurs. We actually think that we have an innate immune dysfunction that is the effector arm, where the root causes at the bottom are the genetics, the diet, age, stress, and other factors that converge to drive the neurodysfunction, the immune dysfunction, and the neuropathology. And so if you think about targeting the root causes in every individual would be very impractical. But innate immune dysfunction and various targets related to immune innate dysfunction would be a tractable target. And so we feel that restoring immune function and treating chronic inflammation is really going to provide the best chance for reducing risk for Alzheimer's as well as progression. And so in my next slide, I basically want to flip the amyloid hypothesis on its head and suggest that, in fact, the genetics tell us, again, that how we view the disease determines how we approach the treatment. And so we believe that innate immune dysfunction is actually what causes the lack of clearance of the pathological amyloid and tau. And these dysfunctional immune cells are then not able to keep up with clearance of toxic oligomers and other proteins. And they perpetuate the chronic inflammation that leads to synaptic dysfunction and stripping and neuronal cell death and eventually neurodegeneration. So again, treating immune dysfunction and chronic inflammation early should provide the best opportunity to modify or prevent Alzheimer's pathology in a significant number of individuals, even if not all individuals.
So thank you, Malu. Very interesting, and I think one of the more unique aspects of the way you think of the disease is that it's not that amyloid causes inflammation, like you said, it's been flipped. So inflammation is really part of the beginning of the story, not the end of the story, and that certainly is not the way that disease has been attacked by both academics and by drug developers. So let's now move to Dr. Sharon Cohen, who's is the director of Canada's largest Center for Alzheimer's Disease Clinical Trials at the Toronto Memory Program. She has, experience in, if not all, virtually every strategy for treating Alzheimer's disease in the recent past, and she brings a unique perspective of the therapeutic burden, or shall we say the disease burden, and the therapeutic strategies that have been used for this devastating disease. Dr. Cohen?
Thank you, RJ. It's a pleasure being with everyone today. You can see from my disclosure slide, hopefully you can advance that, yes, that I currently am a consultant for some major pharma companies and have been for many others in the past, most of these developing anti-amyloid and anti-tau compounds for Alzheimer's, but a whole smattering of other things as well. I'd like to start on my next slide with why we're talking about this at all. Alzheimer's disease was labeled as an urgent healthcare priority as early as 2012 by the World Health Organization, and it continues to be an urgent healthcare priority. It's not just the staggering numbers of affected individuals. Currently, 50 million with Alzheimer's or related dementias, rising to 150 million by 2050, but also the severe morbidity for patients and families. We are dealing with a disease here that is not just common, but a disease of stigma, loneliness, loss of dignity, loss of autonomy, and loss of self. And at enormous financial cost as well to the individual, the family, and to society. Rather than state this in a dollar value, I think it is often impactful to realize that Alzheimer's disease costs more than cancer or heart disease. We don't allot the same proportion of resources to this terrible disease as we do to heart disease and cancer. And finally, this is a fatal disease that is often a fact swept under the table. This is a disease that is often quoted as the fourth, fifth, or sixth cause of death in North America, depending whose study you read. But in the UK in 2016, the BBC declared that Alzheimer's disease actually overtook heart disease as the #1 cause of death. On my next slide, you will see, sorry if we can advance to the next slide, that the current standard of care for Alzheimer's management, that's in the clinic, a patient with a memory concern, what we're dealing with is a diagnosis that is generally late and most times imprecise based on cognitive test scores, which are very variable and don't always adequately sum up what a patient's abilities are. And we prescribe medicines that address symptoms only, work in only about 2/3 of patients, and at best confer modest benefit. There are no disease-modifying medicines, no cure, no prevention at the present time, and no new treatments, not even new symptomatic treatments since 2003, with memantine being the last one that we saw come to the market. So sadly, education and support services, which are extremely important, remain the mainstay of care as affected patients inevitably decline and pass away from this disease. On the next slide, you'll see what the current approaches have been over the past decade. So here I'm talking about in the clinical trial pipeline. The overwhelming major approach has been to focus on anti-amyloid therapies with BACE inhibitors to shut off amyloid production and antibodies to enhance clearance of amyloid, and vaccines also to enhance the body's ability to clear amyloid. Following that have been tau approaches, which are still very much in play, and major tau clinical trials will start yielding their phase 3 results in another year or two. These approaches include largely preventing tau from aggravating and enhancing clearance of extracellular tau to reduce the tau-to-tau spread from neuron to neuron. And there have been a smattering of other approaches for symptomatic treatment. These have been neurotransmitter-based, so again, sort of late in the cascade of what happens in the brain in Alzheimer's. Importantly, some lifestyle modification strategies and an assortment of other approaches, including intranasal insulin. On the next slide, you'll see Jeff Cummings' rendition from 2018 of what the Alzheimer's drug pipeline looks like. It's a complicated slide, but just focus your attention on the following few items. In the orange area, so 1/3 of the pie, we see drugs being developed for symptomatic treatment of Alzheimer's. 2/3, the remaining 2/3, the purple and the green segments, focus on disease modification compounds. So this is a complete flip from what it used to be, where we were only dealing with symptomatic treatments. Now we're focusing on disease modification. That's a good thing. If you look, however, at the disease-modifying approaches, the red represents anti-amyloid approaches, the blue anti-tau approaches, and far and away, those are the majority of the approaches. In the concentric circles, we're going from the outer circle, phase 1, new compounds coming into phase 1 clinical trials, then phase 2, and in the inner circle, phase 3. And you'll see on the periphery in the phase 1 segment, we do have non-amyloid and non-tau approaches coming in. So just starting, and it'll be years before we see results of those trials. I think if we had Dr. Cummings redo this in another couple of years, it would look very different with innate immunity compounds and other kinds of compounds in the disease-modifying pipeline advancing through. Next slide, please. So why should we target the immune system? You've heard from Dr. Malu some compelling reasons. We've known for a long time that inflammation is associated with Alzheimer's pathology, specifically inflammation seen alongside well-established plaques in the neuropil. But attempts at traditional anti-inflammatory interventions have been unsuccessful, including non-steroidal anti-inflammatories and more powerful anti-inflammatory trials with prednisone, and really targeting the adaptive immune system and the idea that inflammation has arisen because of deposition of amyloid plaques. We now have a much more sophisticated understanding of the role of the immune system, and that allows for new approaches based on the preclinical evidence that Dr. Malu has shown in brief, and the availability of biomarkers of the innate immune system so that we can actually track the impact of a potential intervention and not use some of the vaguer outcome measures that we've been using to date. Furthermore, if we target the innate immune system, we have the potential with specific compounds to impact multiple processes that go on in Alzheimer's disease beyond just inflammation. And these include the impact on generation of amyloid and tau, and also the health and neuroregenerative properties of synapses. So what would success look like? In my next slide, you can see what my take on this is. Relevant goals in Alzheimer's treatment include slowing the disease, stabilizing and reversing the disease, and ultimately preventing the disease. Yes, of course, symptom treatment has a role, but far and away, clinicians and patients and families want to halt a disease, and particularly early in the disease when quality of life is still good. One can have mild Alzheimer's symptoms and still be able to do many things and enjoy life. We're trying to apply treatment at late-stage disease when so much of the brain is damaged and a patient is so disabled, one really needs to question the value of that. We also need to have treatments whose responses we can monitor biologically, just the way we would monitor the effect of a blood pressure medicine by checking blood pressure. We need to know in a reasonable time frame that our treatments are working, and if not, move on to a different treatment. And hopefully we would have a variety of different approaches approved and that could be used individually or in combination. And we want to be specific. What we call Alzheimer's disease today is probably a disease that consists of many subgroups of patients, some of whom have inflammation driving their disease, others have other components which need to be targeted. And these combination therapies will allow a lot more flexibility and individualization of the treatment approach. Thanks very much.
So thank you, Dr. Cohen. That's a wonderful overview by a very experienced clinician who leads a large, multifaceted clinical team. And so we've heard about, one of the cutting-edge search areas in the development of Alzheimer's disease and dementia. We've heard from Dr. Tansey. We've heard about the clinical perspective from Dr. Cohen. And now to hear about drug development in this difficult disease by Dr. Larry Friedhoff, who is the Chief Executive Officer of Pharmaceutical Special Projects Group and really has the unique position of being probably the only living soul that has actually gotten a drug approved in this space. And so he brings a perspective that it not only one from success, but I will say from also watching the many failures in the space. So with that, I'll turn it over to Dr. Friedhoff.
Okay. You can show the disclosure slide, which also has my my bias. So, and I did get I'll get an honorarium for speaking here, which I forgot to put on the disclosure slide. But as as mentioned earlier, a long time ago, I discovered this discontinued drug and put it back into development, and it became donepezil hydrochloride. Aricept is just the main drug used to treat Alzheimer's disease, and in fact, all of my drug approvals have been small molecules. So that is my bias, just based on an experience of many years of getting new drugs approved. Now, if you go on to the next slide, I want to just briefly discuss what I always say is the elephant in the room when you discuss Alzheimer's clinical trials, and that's really my experience. I've probably done, been in charge of more anti-dementia drug clinical trials than most anybody else, and essentially all of the ones that I've been fully in charge of have gotten p-values on an FDA acceptable endpoint, I believe, one way or another. But the big issue is, we've had so many years of failures, and why is that, and how do we overcome that? So, as you probably all know, drug development is separated into 3 phases, phase 1, 2, and 3. Phase 3 is the big one, where we determine whether a drug is safe and efficacious in a large number of patients. But the design of phase 3 trials is always based on phase 2 studies. And typically, not so much in anti-dementia studies, but typically phase 3 trials are powered to confirm the results of phase 2, and they're powered to 80 or 90% or more sometimes. That means if power calculations are properly done, 80 to 90% of phase 3 studies should be successful, certainly more than half. Now, with the possible exception of some results that are going to be presented at CTAD, and which I haven't seen in detail, so I can't really comment, in a few days, there have been hundreds of phase 3 AD trials in the last 15 years with zero successes, 0%, as opposed to mathematically predicted 80 to 90%. So what's the potential cause of this discrepancy? And in my opinion, other than the many difficulties of getting drugs approved in general, and I wrote a book on that subject, it's not a trivial thing to get a drug approved. The most obvious problem in AD is the lack, in many cases, of phase 2 results that can reasonably use to power a phase 3 trial. So phase 3 trials are typically powered based on preclinical data from mouse models, for example, and an estimate of the minimal clinically meaningful efficacy. So you sort of think, well, what's the minimum amount of efficacy we'd want to have in order for this to be useful to patients? And then you just assume that your drug has that amount of efficacy and power your study accordingly. And the inherent difficulty in Alzheimer's trials is the endpoints are weak statistically. I call them noisy endpoints. So they're difficult to implement across cultures and languages, and the regulators require statistical significance in 2 of these noisy endpoints. So that's much higher bar than typical for drugs for other indications. Now, the successes thus far, dating back, as was said earlier, of 16 years, have come from drugs that improve cognition and function over baseline, rather than slowing the rate of progression, which is more desirable, admittedly. And that's because acute improvement is inherently easier to show than delay of progression. And I'll try to illustrate that to you in the next couple slides. So the next slide shows a figure from the donepezil package insert. And this shows a change in the ADAS-Cog, which is a measure of cognition. It's a performance test for 3 groups of patients: placebo, which is the dark line along the bottom with the error bars, 5 milligrams a day, which is the next dark line up, and the top line is a 10 milligram dose, which is the most effective. And I'm going to concentrate on the 10 milligram dose. So the arrow on the right shows you the treatment effect at the end of the study. That is the difference between the 10 milligram dose effect on ADAS-Cog from the placebo effect down at the bottom. And as you can see, much of the benefit of the 10 milligram dose comes from its improvement above baseline. So you see the little dotted line running along the middle of the graph. That's where the patient started out. And so that red arrow shows you the difference between the top dose and placebo, and much of it is above that little dotted line that shows baseline. So the bigger that difference is, obviously, the easier it is to show p-value and get a successful clinical trial. Okay, now the next slide, I'm going to try and show you what happens when you use a disease-modifying drug. And I'm not convinced that there's a clear line between symptomatic and disease-modifying drugs. But if you have a purely disease-modifying drug, then what I've done is I've grayed out the active drug lines from the Aricept package insert above the baseline. And that red line then shows you the average, skipping over the first visit, the average rate of decline of these patients over the 24 weeks of the study. So I've taken the black line, which is the actual observed data, and sort of by eyeball fit that red line to say that's about the rate at which these placebo patients decline, and it is consistent with what's been reported in the literature for the rate of decline of placebo-treated patients. Now, let's suppose we have a drug that reduces that rate of decline by a quarter. That's what I've tried to illustrate with the orange dotted line. So that line has a slope that's a little bit less than the red line, which is the slope of placebo. So your disease-modifying treatment is slowing the disease a bit. Now the active and placebo difference is shown again by the red arrow. And as you can see, that red arrow is an awful lot smaller than what we had with donepezil. So what that means is, since you have a much smaller treatment effect, you're going to have a different study design. And what difference do you have to implement? Well, the difference between active and placebo is increasing over time. So you could try and make that red arrow bigger by waiting for a longer period of time. The alternative, and not mutually exclusive, is to just say, well, we have a small treatment difference, so we'll use more patients. And the reality is that both kinds of strategies have been implemented, so that studies of disease-modifying agents have been very large and gone on for very long periods of time. And if you, that means much larger, longer, and more expensive studies. That means greater exposure of patients to potentially ineffective or harmful experimental therapies. And it's especially worrying if there are no phase 2 studies that can be used to properly power these very large, expensive, long studies. And I think that explains the many failures over the last 20 years. So what can we do to try and fix that problem? Well, I'll try and give you an analogy from driving. You probably all have driven or been in a car driving. So I'll just say that it's much easier to tell how fast you're going by looking at the speedometer once rather than measuring the time it takes to go from 1 mile marker to the next. That's why we all use speedometers and we don't use mile markers. Similarly, a point assessment of the rate of neurodegeneration is preferable to the assessment of a functional change over a long period of time. And biomarkers that assess the rate of degeneration of other kinds of cells rather than neurons are used all the time in clinical medicine and in the drug approval process. So, for example, liver function tests are used to evaluate the progression of hepatocyte damage. The higher your LFTs are, the more quickly your hepatocytes are dying. And the same thing for cardiac damage, and I'm sure there are many other examples. So you measure release of cardiac enzymes, that tells you the instantaneous rate, more or less, of cardiac damage. And if you integrate that over time, it tells you the actual amount of cardiac damage. So how can this be adapted to the situation of Alzheimer's clinical trials? So if we go to the next slide, I'll just show you a figure from a publication of a study looking at CSF levels, cerebrospinal fluid levels of neurofilament light chain, a potential biomarker in neurodegeneration, and serum neurofilament light chain levels in the panel on the right. And this study was done in patients including patients who have a gene that predisposes them to early onset Alzheimer's disease. So the patients who carry that gene are shown in the red, and the people who don't carry that gene are shown in blue. And the scale on the bottom is years to expected onset of dementia signs and symptoms. And this is something that's pretty well defined for the carriers of this gene. And what you can see is even 5 years, and the red shading and the blue shading show the 95% confidence intervals around these values. So what you can see is even 5 years before we can measure clinical effects, this biomarker is elevated in the patients carrying the gene, the people who are doomed to develop dementia 5 or more years later on, both in the CSF, and it's hard to see because there are more values, but the same thing is true for blood. So these results suggest that a single assessment of this biomarker at a single time could be used to assess drug efficacy. And if you go to the next slide, I'll give you some ideas of how this new reality that there are neurofilament light chain and other biomarkers which appear to correlate with the rate of neurodegeneration could change Alzheimer's drug development. And there are two big constituencies here. One is industry. So in pharma companies now can conduct may be able to conduct phase 2 studies of disease-modifying drugs using biomarkers to properly power phase 3 clinical trials. So they may be able to actually figure out what dose regimen, what duration of treatment is necessary to show at least an effect on a biomarker. The regulators, as I mentioned, have required 2 endpoints, 2 clinical endpoints, 2 of these clinical noisy endpoints for approval. In mild cognitive impairment, there's now a change in the regulations so that it's possible that a biomarker could be used in place of one of the noisy clinical endpoints. So if that is extended to the treatment of Alzheimer's disease as well, then that would be a lifting of a significant part of the extra clinical statistical burden for the approval of AD products. And why is this important? Because biomarkers for the rate of clinical decline could be, in my opinion, a game changer in AD drug development. Effects could be potentially seen in short studies. Neurofilament light chain seems, from what I can read, to change relatively quickly in response to drug effects in diseases other than Alzheimer's. I think that's been evaluated in Alzheimer's. They may be less noisy than these clinical endpoints we've been stuck with for many years. And biomarkers for the rate of clinical decline could facilitate recruitment of patients who are declining rapidly. Even if the clinical endpoints aren't changing rapidly, we might be able to say, well, they're losing neuronal function rapidly. We just don't see it in signs and symptoms yet. And of course, the faster the placebo group declines, the easier it is to see a treatment effect from an active drug. And this could lead to shorter, smaller, less expensive studies. And the next slide, I think, is just my conclusions. So development of disease-modifying drugs has been hampered by, I think, the lack of properly powering, the inability to properly power phase 3, statistical endpoints, statistically noisy endpoints, and the acceptance of biomarkers like neurofilament light chain for prodromal AD, which the FDA may very well do, and perhaps even for AD itself, could reduce the statistical risk for developing disease-modifying therapeutics. Biomarkers may be more statistically powerful just because they're harder endpoints. They may make phase 2 studies much smaller and much faster, And good phase 2 studies should make phase 3 studies much more likely to be successful, perhaps in the 80 to 90% range, which is really where they should be if you have proper phase 2 studies. So I'm hoping that towards the end of my drug development career, that things will be easier for the next generation of people developing these drugs because of these new tools, many of which have become available pretty recently.
Larry, Dr. Friedhoff, thank you very much. It's a very interesting perspective that you give. Certainly is not something you can pick up at your local corner drugstore. So your long experience is really shown in that analysis. So now I'd like each of the participants to just be ready to go off mute, and I'm going to just start some questions and see where the conversation goes. And I won't be shy in saying, part of what stimulated this webinar is the fact that on Thursday we have Biogen is really going to be discussing their aducanumab trial results that they are proposing are now support the use of the drug to treat Alzheimer's disease. And this is after actually declaring the strategy null and void in April. And so, Dr. Tansey, just maybe you can comment if the strategy of attacking amyloid based on current knowledge, particularly your current knowledge, is a rational approach or it's an approach. And that is to say, our anti-amyloid strategies, let's assume that they're going to have good things to say on Thursday. Does that mean the problem is solved, or does it just mean the beginning of success has begun?
Yeah, that's a great question. I think that what problem with current amyloid strategies is that they're probably starting too late. So we need to be a little bit more proactive about targeting amyloid that is toxic, not necessarily the plaques and dismantling the plaques. And so if immunotherapy is going to prevent the accumulation of the toxic amyloid, then it probably still needs to start earlier. And again, it's a little bit like an analogy that one of my colleagues once used, and that is that the immune cells in the glia are the support cells for the neurons. And the neurons are having some signs of neglect by the glia that maybe have a little bit of dysfunction. And you could remove the caretaker, if you will, but then the neurons will probably die of neglect. And so what you need to do is you need to have a strategy where you put the immune cells in rehab, if you will. So the targeting of innate immune dysfunction is likely to get you more earlier than if you target a consequence of that immune dysfunction.
So could I just jump in at Sharon?
Yes, please, Dr. Cohen.
To comment on that. I think that if there are successful anti-amyloid approaches, and success meaning some disease slowing, that is a welcome outcome. Amyloid does not have to be the original cause of the disease. It just has to be an important contributor to clinical progression of the disease, just the way tau doesn't change early in the disease, but it may drive disease at some point. I think that when we're dealing with a complex disease like Alzheimer's disease with multiple different processes going on in the brain, yes, you want to go early, and if immune dysfunction is happening early, let's try and correct that. But that's not to the exclusion of other things that might also assist. So I do think that if anti-amyloid approaches show some benefit, that is, as you put it, RJ, the beginning of a new era of disease modification, and let's build on that.
So I think what you're saying is that number one size doesn't fit all, and that combination therapy, which is really the mainstay of the management of most complex diseases. I mean, look at heart disease. I mean, the average, 60-year-old male in the United States is on a antihypertensive, a lipid-lowering drug, and a baby aspirin every day. That's 3 drugs for managing what is a relatively common disease. One drug is not enough.
Right.
So Larry, I mean, this idea of it's a lot easier to develop a drug for a symptomatic endpoint versus a disease-modifying endpoint is a bit of an eye-opener to me. I've never seen it presented that way. Should those of us that are developing drugs for Alzheimer's be trying to find that symptomatic endpoint so you get that big delta, or is the reality of the disease, the clinical reality, that disease modification is the case, and we really need to find that perfect biomarker?
Well, I think with a serious disease like Alzheimer's, you got to take what you can get. So if you find a potentially symptomatic treatment, it's certainly well worth trying to get a product like that approved and into the hands of physicians and patients. Given that people become significantly symptomatic oftentimes at a pretty late stage in their life, a symptomatic treatment can become somewhat equivalent to a disease-modifying treatment if the symptom relief is sufficiently, good enough. So if it prevents them from progressing very much, if they get so much better that they don't get back to baseline for 10 years, then you've essentially modified their disease in a meaningful way. And I also think that it may, to some degree, be a distinction that is hard to truly make. There are many people who believe that cholinesterase inhibitors actually slow the rate of progression of Alzheimer's disease. It's, in my experience, the active placebo difference does tend to widen over time, which suggests a difference in slope between treated and placebo patients. It's just a lot harder to see disease modification than it is to see symptom improvement. But that being said, the diagnosis of a heart attack now can be made pretty accurate. I'm not a cardiologist, but as I understand it, you measure these cardiac enzymes and somebody's got cardiac damage, and you can tell pretty much how bad it is by measuring those things serially. And later on, people can develop heart block and all these other complications of a heart attack. But a single point measurement can tell you the intensity of that person's disease at that moment. And then you can give them a drug which reverses the damage, which prevents the damage from continuing and getting worse, and you'll see that enzyme drop right back down to 0 again. So you open up a coronary artery, blood comes back, eventually those enzymes go away. So I think if you can find the right biomarkers, and I'm not an expert on this, these are just tools that I try to find to use, I think you may be able to show efficacy a lot more quickly and a lot more cheaply using these biomarkers than you can using the clinical evaluations, which are, as was said by one of our clinicians earlier, these are very imprecise things. And so you have to wait a long time and wait for a very big difference before you can be sure that it's real. So I think with the right biomarkers, we may be able to get disease-modifying drugs approved just as easily as we did with symptomatic ones.
Thank you, Dr. Friedman. Go ahead, Malu.
Yeah, I just wanted to jump in here. I completely agree with what Dr. Cohen and Dr. Friedhoff said in terms of not one size fits all. And of course, it would be a welcome event if indeed higher doses of the immunotherapy and the aducanumab will give a better result. What I would say in terms of biomarkers is that everybody in the biomarker world sort of has their favorite biomarker, and that also has been a little bit of looking where the light is. And, you know, it's been interesting in our experience to look at some of these neuropeptides within the context of the inflammation that you see in the biofluids. It's a lot more informative to interpret some of those findings when you also look at the inflammation and the immune cell phenotypes in those patients. And we've done a little bit more work that's published in the Parkinson's space. But I think it's important to have a more holistic and broader view of, you know, a biomarker so that we can think about how to define sort of inflammatory endophenotypes or inflammatory traits as opposed to a specific inflammatory state that the person may not be in at the time where the blood is drawn. So it's important to keep looking for biomarkers, but have a little bit broader perspective of how to interpret existing biomarkers with new biomarkers and integrate the knowledge such that we get a more comprehensive picture or profile, if you will, to get a better way to stratify patients and select them for trials and then to measure responsiveness.
Yeah, and if you can follow up on that, Malu, I mean, talk about microglial activation is driving inflammation, but you know the biggest risk for Alzheimer's disease is age. What is that connection between age and inflammation and the development of Alzheimer's disease? Is the source of the inflammation local, regional, or peripheral, or all of the above?
Yeah, that's a great question. So Garanzi and colleagues have done a lot of work out of Stanford looking at the aging of the immune system in humans. And it's clear that it's kind of a double-headed monster. It's a little bit of immunosenescence and inflammaging, or, you know, it's kind of an age-related autoimmune deficiency. So the innate and adaptive immune systems are not really playing with a full deck. The diversity in the receptors on T cells and B cells shrinks. The compartments for myeloid cells, or the cells that are microglia and monocytes that are making most of the inflammatory cytokines, are increasing in frequency and numbers as you age. And so it's not specific to the brain. It's actually been recognized to happen in peripheral organs. And so I think it's a whole organism event that contributes and sort of raises the level of inflammation everywhere. And your brain, you know, is not immune privileged. It's immune specialized. And so it senses what is happening in the periphery, and there's communication between the periphery and the brain. And some of the microbiome studies in the gut suggest that what's happening in the gut microbiome is affecting what's coming out of the bone marrow and what the microglia are doing in the brain. So I think it's all connected.
Yeah, so Dr. Cohen, if you know, assuming my simple assumption is that we're going to hear some very positive news on Thursday with the Biogen report, and there's going to be enthusiasm in the field for new drug development strategies. As a clinician and an experienced clinical trialist on the front line, how are you going to manage when two companies show up at the same time with a drug? Obviously, they're working by maybe different mechanisms. Let's say it's us with our Expro 1595, and even Biogen, who wants to repeat their phase 3 trial. I mean, how are you going to decide how to combine those drugs, and if to combine those drugs? Or at this point, and I don't mean to put you on the spot, you think that whole story is an evolution?
We're definitely eager for combination therapy. The field's been talking about this for a long time, but sadly there have been very few combination therapy trials in Alzheimer's disease. I think you're right that if there are positive phase 3 results with Biogen's announcement, that will energize the field, not just the anti-amyloid component of the field. It will certainly do a great deal to bolster those who have anti-amyloid compounds. But the field in general, because there have been so many failures and so much discouragement, that people really need to feel that finally there is something, even if it's not a cure, if it slows down disease a little bit. I can tell you my patients are excited about that. Their expectations are tempered, and we need something to motivate us further. How do we choose what compound or protocol to enter patients in a trial in? We've always had that scenario where there's more than one trial that an individual might qualify for. The inclusion and exclusion criteria, generally differ. How mild the patient, what kind of biomarkers need to be satisfied to enter a trial. So it generally sorts itself out, and we're happy if a patient has one trial they can go into. If Biogen is successful in bringing aducanumab to the market, that could serve then as a background therapy once approved, just the way individuals who join clinical trials now in Alzheimer's disease can be on background cholinesterase inhibitors. So if they are allowed to be on aducanumab and add something to it, that can work. Or head-to-head trials, comparing aducanumab with a still experimental drug, that can work as well. So I think there are many opportunities to move forward.
Yeah, and Larry, you mentioned in your discussion that you sensed that one of the problems was the FDA was requiring too noisy or imprecise endpoints, and that had made the hurdle quite high to clear, and suggestion that the biomarker, a biologic biomarker strategy, offers lots of advantages, which makes great sense. How do you connect the dots between the current position of the FDA and the use of biomarkers as a, shall we say, a validated surrogate endpoint? Does it require those long trials, or do you think there's a way you can get to surrogate biomarker-driven decision-making sooner than later?
Right. So I think you kind of asked two questions. One is what the FDA requires, and the other is how you could get to designing a study that would satisfy FDA. So let me answer the first question first, and that is the FDA now has two guidances for describing what's needed to get approval for treatment for Alzheimer's disease as a disease, as opposed to psychosis and Alzheimer's disease or some other related symptom of Alzheimer's. So for Alzheimer's indication, like the cholinesterase inhibitors have, for example, you need two clinical endpoints. They're both noisy, and so it's a if you have a very effective drug, you can do that. If its efficacy is not, it's weaker, and it's difficult to satisfy it with one endpoint, let alone two, in a single study. Now, for pre-Alzheimer's disease or mild cognitive impairment, there's another guidance which says that you can substitute a biomarker for one of these noisy clinical endpoints. The guidance does not specify what biomarker the FDA would accept, and so it's not clear to me what they would accept, and so a sponsor would have to go and discuss it with them. But in talking with experts in the field, and I'm not an expert on biomarkers really, I think their feeling is that some of these biomarkers are getting to the point where FDA might very well accept them. And then you have something which hopefully, if the assays are done well, and the levels seem to be relatively stable in patients, then you have one of these two endpoints will now be statistically much more powerful, hopefully. And that, greatly lowers the barrier for getting a drug approved. The second is, I think soon, if it hasn't been done already, there'll be correlations between the biomarkers and rates of change of some of these clinical endpoints. And once you have that, then you can power a phase 3 study just based on biomarker data, because if FDA agrees to accept biomarkers in AD, which I think would be reasonable given that they've accepted the concept for pre-AD. Then you could do a short biomarker study, and from that you could estimate how many patients you need to move the biomarker. And if there's a correlation with change in some of these clinical endpoints, you could then estimate the number of patients you need to achieve a p-value on the clinical endpoint as well. And you would get that without having to do a long study of the clinical endpoint. So I think that makes phase 2 studies a lot easier, a lot faster, and should improve the pretty miserable record of phase 3 trials in this area over the last 15 or 16 years.
So with that, I'm going to wrap it up. We have 2 minutes left till the top of the hour, and I know many of you have sent questions, and we'll try to get those back to you, either answered by those of us in the company or by our expert panel. We hope, though, that you've learned something today. At the end of the day, our goal has really been twofold: to really support the fact that Alzheimer's disease drug development, I think, is entering a new era. It is a disease that is complicated, will require multiple solutions, and those we now have tools both in the drug development space and the drugs themselves that give us a chance. And with luck, we're going to learn on Thursday that the regulatory environment has also gotten to the point where they will put wind in our sails. So with that, I appreciate all of your participation, and I particularly thank our expert panelists, and have a good day. Thank you.